is here today, truly, who gets more tachypnic than the Disney cat when it shows up? You can put your hand in the air. Okay, great. So hopefully I can help some of you today. And the other ones, maybe we'll get a little extra tips on the management of these patients. So every time that we talk about patient that can't breathe, that basically says that there is a change either in their respiratory rate. Normally they're breathing faster, but not always. They might actually be breathing slower. Or the effort that they're putting into their respiratory movement. It's basically what we say, it's in respiratory distress. And it's uncomfortable, creates a degree of anxiety. And obviously, the more is the effort or the worse is the level of dyspnea, the more at risk our patient is of suffering respiratory arrest. I'm going to steal that. Yeah. So the way that I built this presentation is how my brain was designed, let's say, over the time of years that I've been dealing with dyspneic patients, such in a way that not only we keep calm, but we keep focused about what do I need to clarify to help this animal as soon as possible and relieve these potentially life-threatening dyspnea. So the first question that comes to my mind when I have a dyspneic patient is this an upper airway problem or a lower airway problem? Okay, so this is the first thing that we need to clarify as soon as our dyspneic patient arrives as an emergency setting. If you look at this little puppy here, this is a 3-month-old puppy, had a thoracotomy because there was something odd on his lung that now we have confirmed to be, unfortunately, pulmonary carcinoma. Is there any component of upper airway as well, and why not? Anybody thinks that he's also struggling with upper airway? To me, two things. One, we cannot really listen to him breathing, but he's breathing really fast. And if a patient is breathing really fast, normally the airway is available for the air to pass, okay? But he's putting a lot of effort. So most likely, the majority of the concern is down his throat. And I already told you why at this stage. What about this gentleman? Our favorites. We love it. Or not. What do you think? Anybody thinks he's got lower airway problem? I'm going to say he might. He could. He's a bulldog. He already had breakfast, probably already aspirated that. But just now, what can become life-threatening for this patient is an upper airway concern. And if you look at him, he's still breathing quite fast, right? So he's still able to pant. If we could just put, thank you. Still fast. So something is passing. And now you're going to say, he looks really pink. We will talk about that. But this is the dog that could just have presented to you for the normal vaccination. This happens to everybody. Comes for a vaccine, and yes, mom will say, this is how he breathes. Yes, we know that's how he breathes. When he's at home with mom, calm in his environment, he already lives in dyspnea. The moment the bulldog, French, English, whichever, and the pug, arrive to the consult, moms can be calm, you cannot be calm. Because they are so desensitized to hear their dogs like these that they'll have the dog like this in reception and be totally cool. And the moment that you see the dog, he goes from pink to purple in 3 seconds, okay? And they die just like that. So this dog that is here for a vaccination, you have two options. Either you vaccinate him right now and ship him back to the car, probably already with something on board, or he needs something to calm down before you do anything else to him. Otherwise, he will progress with this. What about cats, our favorites? Is this an upper or lower airway problem? Who thinks he's upper? Air in the end, in the hand in the air. Okay, we have some votes. What about lower? The majority votes for lower. Can anybody say why? There is inspiratory, expiratory, is mostly inspiratory, but it's still a little fast, okay? Now, cats are really tricky because the bulldog, you can hear him from like Marlowe, right? But the cat that is with upper airway obstruction will not be so upfront at showing you that. So when I look at a cat like that and I say, I don't think he's upper, is mainly, again, because cats that have an upper airway obstruction will have slow respiratory rates. Remember that, slow, because they're dramatic. They're like, or with their mouth open, right? That's what they do to freak us out. So that one is not doing that so violently yet. So I say most likely it's something down his chest. What about this little kitten? Who thinks he's upper? Okay. Who thinks he's lower? Who thinks he's both? We have a few votes for both. This is a tragic case, okay? So this is a kitten that was involved or was rescued from a house fire. You can still see some of the debris. That's why he looks a little grayish. And this patient needs emergency intubation. That's basically what this video serves to show us. This is not going to be sustainable for much long. If you pay attention, he's totally full of saliva and drooling. It's not because he's feeling nauseous. He can no longer waste his time to swallow. That's the severity of the dyspnea. And there is indeed a component of upper airway obstruction. He's all stretched, is not super fast, his rate, because everything has burned down and is severely swollen. Unfortunately, as you can imagine, if that was at the top, the same was happening at the level of the parenchyma. So all of his respiratory tract had been totally compromised. So the second question, once we were able to say, is it upper or is it lower, is how severe is it? How urgently do I need to stop doing what I was doing right now to go and pay attention to this patient? So let's look at these gentlemen. First question, upper or lower? Who thinks he's upper? Some. Who thinks he's lower? What's the severity of his breathing abnormality right now? Who thinks he's mild? Okay, who thinks he's really bad? It's not really bad, we all agree, okay? This is an old Labrador. He probably just had a TPLO, something done, and he's recovering, and he's starting to tell me on the way that he sounds, and by looking at his facial expression, I'm not dealing with these very well right now. And he's not necessarily dyspneic, but he will become, because what he's showing me or letting me listen is laryngeal paralysis, okay? That's what he's got. I don't need to do any fancy tests to know that. And I know that just now, if this dog starts stressing more, overheating, feeling pain, these can become a crisis. So I say, okay, I just saw you doing that. I'm going to prescribe you some sedatives or something like that, and we're going to keep a close eye on you. But we don't need to intubate him or anything like that right now, okay? Okay, next one. What about this pom-pom? Upper or lower? Who thinks he's upper? Who thinks he's lower? I'm going to assume the other ones are not sure. So let's look at him again. I actually had the sound on purpose. Oh, sorry. Because what can you hear? Noise. He's in an oxygen kennel, right? There's people talking. This is the reason why some of my, or actually probably by now, all of our ICU team at the Ralph knows how obsessed Marisa is about the oxygen kennels and potential upper airway obstructions. If you have a big ICU, a big room, or if you have a big clinic and you put this little guy in a little cage with oxygen because he's struggling and you turn around, he dies unattended, easy and fast. Okay, so I actually put the sound on so you guys see the struggle on looking at him. I know what's going on. Let's do the pattern recognition. It's a little Pomeranian. They don't have good tracheas. And he's doing this. Again, slow respiratory rate, tongue totally out, opens his mouth a lot. He's obstructed. He's totally obstructed. If you would have him outside of the oxygen kennel, you could hear the, but there he's silent. He goes unnoticed, okay? So this is a classic upper airway obstruction. What's the severity? Very severe, okay? He already received some butorphanol. He's already on oxygen. What do we do now? He needs to be intubated. That's it. All right, what about this guy? Upper or lower? Anyone think he's lower? Maybe, okay. What's the severity? Are we going to intubate him right now? No, okay. What are we going to do now? Yeah. He's already on oxygen, exactly. And I say, well, can you tell us something about the dog? Well, I can tell you this is a cane corso. It had an abscess. He went to the operating room. He didn't need any oxygen. He was totally fine. He comes back from the operating room, and he's already on oxygen, some nasal prongs, because anesthesia was worried about his breathing, and he's like this in his kennel. Who thinks he's anxious? Everybody. He's crying. He's freaking out just now, okay? And there could be also a component of pain. Of course, that we pair that with the fact that he's a cane corso, probably a little fat. He does have a little bit of boas, and hence this stutter and this vicious cycle will continue until you're able to block it with whatever he needs, whether it's analgesia, whether it's some tranquilizers. The worst cases will need to be reintubated, but this dog just now, his main concern is probably stress, anxiety, and pain, not actually a true respiratory primary problem, okay? What about this one, the top one? Upper or lower? I hear the majority saying lower. I agree. For the ones that are not sure, because the rate is not so fast, look at his mouth, closed mouth. 99% of the dogs, if they have an upper airway obstruction, their mouth is wide open because they're trying to open the airway, okay? What about the effort? Mild, moderate, marked, severe? It's quite marked. He's putting quite a lot of effort there, okay? Now, do we need to change anything? I can tell you that this is a patient with pulmonary thromboembolism. Is this good enough for now, or we're not convinced? It's hard, because the poor little guy looks like he has pretty bad effort. But we also know that he's got a disease that now we need time, blood thinners, and tons of patience, which vets are bad at. So to me, what I'm going to read, and I would like you to read from this video, is yes, I have a patient that is a big watcher. I want this patient to be monitored really closely, because if this effort becomes faster, he's going to fatigue. Okay, he's not going to be able to cope with that. But for as long as the rate is not so fast, I think we can look at him and say he's still able to lie down, he's in a comfy bed. Hopefully, if he doesn't get worse, he'll be able to tolerate these until his disease process starts improving. What about the bottom one? We can take away the audio of this one. So do you think this is upper or lower? Lower. Closed mouth, breathing fast. Okay. What about the severity? Mild, moderate, marked, severe? Moderate. Okay. But if you look at her, again, always take into account the demeanor of the patient. Yes, she's putting a decent amount of effort, but she's looking around, interested in seeing who is touching her, what's going on around her. So that tells me that this patient is not going to arrest right now, okay? We have time to plan things and take care of her appropriately. What about this boy here? Upper or lower? Who thinks he's upper? Who thinks he's lower? This is a peri-arrest patient. It's very hard sometimes to understand right away what's going on. But when he's breathing, he's passing air. He just lost his strength totally. He's fatigued, okay? What's the severity? Upmost, right? What do we need to do here? Intubate or euthanasia. He will die. If you have a patient that is breathing with this pattern, this is the book type orthopneic position that we all get taught in the vet school, right? Totally extended, totally neck extended. He cannot lie down, sitting up. He does pause on his breathing. If Elliot so kindly plays it again. Pay attention. Pause there. Oh, no. The dog pause. You continue. Pause here again. When they start pausing their breaths, this is the end, okay? This patient in reality should have been intubated way long before he got to this level. And it's not so easy for you to see on the video, but his tongue was, purple is no longer even a possibility for him. He was gray. He's dying, okay? So intubation or euthanasia. There is no other kinder option for him. So, taking a breath ourselves. You see these. You say, okay, the cat is quite stressed and can't breathe. Put him on oxygen. Is that what you say? Or everybody kind of freezes? What do we do? What do we do with this cat? He's breathing like that in the carrier. Oxygen. Oxygen, okay? You look at him, and even if you're not quite sure just now if it's upper, lower, etc., you look at the dyspneic patient, and as you are starting at the same time, because we multitask, thinking what is going on, you tell your nurse, oxygen. I need oxygen for this patient right now, okay? Next. It's never wrong to give oxygen, basically. It's recommended for all cases, and if you're not sure if the patient is dyspneic, just give it. It's not going to hurt. And then, if it's not necessary, you can just discontinue. That easy, okay? You have a variety of options to give it. Maybe you will be more or less limited depending on the practice that you work at, but generally people have either a concentrator or some other source of oxygen, even if it's little bottles. And we tend to use normally either face masks or flow-by, prongs, cannulas, and these two tend to be reserved for referral level, which is the high flow oxygen administration or mechanical ventilation. What you need to make sure is if you have a patient that has an abnormal breathing, definitely is primary respiratory disease, because the last thing that we want to do is to receive a dog that is in hypovolemic shock he will have abnormal breathing, but you pop him on oxygen, and that is not going to treat the underlying problem. So always take into account that we need to rule out other problems, non-respiratory ones, that could be causing an abnormal breathing. If you would like to quantify how bad is the respiratory compromise of your patient, this tends to be the little device that everybody loves and hates at the same time, because we all need it, but it never works. It's the pulse oximeter, and it's very practical, it's very portable, readily available. The problem is that can be influenced by the hair, by the skin color, by the light around the probe. So always take into account all of that when searching for the best place where it's going to read. Our nurses tend to be passionate about imagining where else, maybe in the vulva this time or the ears, so we can let them lead that. But unfortunately, it's not 100% accurate if we don't think that we have a good pulse wave there, okay? And when it comes to talking about the pink color, he's pretty pink. Well, the reality is that if you pair the pinkness with the pulse oximeter, it will go down to about 67%, and normal is above 95. So 67% is severe hypoxia. It will have to get that down by the time that you can see that the dog is purple, okay? So when we keep saying or looking at the bulldog, yeah, he's still pretty pink. Well, the bulldog is one that will switch very fast. But for cats, for example, it can also be something very tempting to say, oh, his tongue is pretty pink. But if the cat looks like he's struggling, he's probably very hypoxemic, okay? If you have an anemic patient, take into account that this machine and the collar relies on the hemoglobin content of the blood. So if you don't have a lot of hemoglobin, which is what is going to lead to the anemia, you will not see the color change on the mucous membranes of your patients. So your patient can actually die before you see any obvious cyanosis in very severely affected anemic patients, okay? But generally, this tends to be the machine that we use to quantify how bad is. And then when you say, okay, no, I'm pretty confident this patient is truly struggling respiratory-wise, I am going to prescribe oxygen therapy, then we should adjust the technique and the oxygen flux to the patient's discomfort, the patient's exercise tolerance, and also to the underlying disease problem. So if we look at this girl here, I can tell you she is in congestive heart failure. She is receiving oxygen already via prongs. How bad was the effort? It's pretty moderate, let's say. What do you think of her pulse oximeter? So remember, we want it above 95. She's at 87, receiving oxygen already. So she's hypoxemic with a decent effort, a decent tachypnea as well. So I would say this is not working. What would you do for this patient? Yes, perfect. I love that. Some people get tricked in this question because they start thinking intubation. No, the first thing that we need to say is, okay, hold on, how much oxygen are you giving to the dog? And if the dog is on 1 liter per minute, well, we have so much to go, and you guys have that accessible in your practices as well. Just increase the flux. And that's what we did. We increased the flux, we fixed her hypoxemia, and we gave time, lots of time, and furosemide. So the majority of times that you'll receive a dyspneic patient, ideally you would have access to one option of these. Some might be luckier and have access to many of them. The flow-by is literally when we have that little tube with oxygen that we just hold in front of the patient. Now, it's very subjective, the amount of oxygen we're giving, because it's just a little tube with that flux, but it's better than nothing, okay? So any source of oxygen tends to be very well tolerated because we're just holding that little tube in front of the patient's face, very hands-off, but we don't know how much oxygen we're giving. If we escalate to face mask, In theory, it's hard for us to quantify. It will deliver a higher amount of oxygen just because we have all of the face covered by the face mask, but it's not so well tolerated, particularly by cats. Another thing that you guys need to take into account with the face mask is either you have a anesthesia circuit for them to exhale and all of those gases to go out, or in this case the CO2, or it's not uncommon to see people just attaching the flow by cable to a face mask. You cannot put that totally obstructing the animal's face, otherwise they cannot exhale, okay? So it needs to be a little bit far away to promote evaporation. Oxygen chambers, what you might just have is those little oxygen tanks, the plastic tanks. Some more advanced hospitals will have true chambers. They're one of my favorites. Why? Because we don't need to touch them, okay? And we don't need to put tubes in their face, they hate it, in their nose, etc. The fancy ones, like the ones that we have, will allow us to titrate the amount of oxygen, humidification, temperature. I know that some of the tanks have some valves that you can adjust, the ones that are available for general practices, and you can, with those valves, determine the amount of oxygen you're keeping inside of the chamber, okay? But remember, if you have a bulldog, don't put him there. So these are just examples. So here is the face mask. So see here, this patient was unfortunately sick enough that he would tolerate total attachment of the face mask to his face, but the face mask is connected to an anesthetic circuit, so it allows the exhalation air to flow out. And this is what would be a fancy oxygen chamber. For the ones that have never seen it before, they're very comfortable, a variety of sizes, and yes, we just have the patient there doing the oxygen therapy very comfortably. And then, if you say, well, I am going to hospitalize this dog with whatever is the problem that has caused the dyspnea, and I actually have access to nasal prongs or nasal cannula or a static source of oxygen, then these are very good options. The prongs are just the simpler ones. You just put them around. It's like that kind of Corso hat. Put them in their nose. They tend to be well tolerated. However, if the patient is very bright and naughty, might just displace it with their paw. So sometimes we do need to have an e-collar. The cannula means that you are inserting a cannula in the nasal cavity, and it does need to be sutured. It can still then be attached to the oxygen source, and many patients, this tends to be used for dogs, they will tolerate it very well. The advantage of the cannula is that if you want to get fancy, you can actually quantify the amount of oxygen you're prescribing to the patient. The reality and my advice is, yes, these numbers are nice, but the importance is how is the patient breathing. If the patient looks like still needs more oxygen, we give more. If the patient appears to be comfortable with just a little, that's fine. Whatever is the number we're prescribing, okay? So these are examples again. Nasal prongs, very easy to put, very well tolerated. And then this would be a case of a nasal cannula that this little guy has sutured here on the side, and then we're able to take them even out, which is nice for them to go outside to wee, attached to a portable oxygen tank. The humidification of the oxygen tends to be neglected. Makes me very sad, but makes even sadder the pulmonary parenchyma. Every time that we are breathing, if you think about all of us just now, well, humidity now it's a little above normal because we're all concentrated here. But if you go outside, you're not just breathing dry air, okay? That's actually very desiccating to the respiratory tissues. So every time that we are providing oxygen to the patient, we want it to be humidified. Because I know that not the dry air, but the oxygen itself can be toxic to the respiratory parenchyma, okay? So whenever you think about giving dry oxygen, all of the cells that line the airways start getting inflamed, coming out. They are not able to promote the mucociliary system as well. So all of this normal secretion that we create is not able to be expectorated, coughed up, just sits there, And of course, bugs will take advantage of that and will promote development of pneumonia. So in our hospital, we have our wall outlet where we adjust the oxygen canister, and then we can just put these little cups. It's nothing special. You can use tap water. Maybe the gold standard would be water for inhalation, but anything that just promotes humidification of this oxygen that will then be delivered to the patient. What about the brachycephalics? Going back to our favorites. That's my face when somebody brings the little pug that got a tika. Everybody does a tika. But then the nurse that intubated the patient, maybe for you, says, I'm just so worried because I could barely see that glottis and I don't know where to put the tongue because the tongue is literally bigger than his face and I just don't know. Maybe he extubates with you. And you're like, okay, I'll try. Or this guy, right, that is, if you pay attention, if you can see, he literally has no holes on his nose. The reason why he's breathing with his mouth open and he's pink is because he already had an emergency tracheostomy that I had to do because he arrived purple. But yeah, we gave him an airway and so he's okay. But the reality is that, unfortunately, the human race always inventing amazing things. They are born to be dyspneic. We created animals that are designed to die at the veterinary practice. So we need to be ready to help them because it's not their fault, bless them. But this is a subset of dyspneic patients. Summer is coming and it will be common. I'm sure that everybody here has struggled with a dyspneic brachycephalic, and then you're like, I'm not sure what to do, or I'm not sure if I did the right thing. So we know that it can happen at any time, but again, if it's warmer, it's even more likely. The majority of brachycephalics that are struggling with breathing will have a degree of hyperthermia. Because it's a vicious cycle, right? They cannot breathe in, but they can also not pant efficiently. So they cannot evaporate and get rid of their heat. So many times we need to break that vicious cycle of, I'm stressed, I start panting, I can't breathe, I also am now getting hot, I cannot get cool, so now I'm getting hotter, I'm getting more stressed, I also can't breathe, okay? And this is this vicious cycle that we need to intervene on. So remember, first thing, oxygen. Second thing, this is my favorite cocktail. I don't mind if you are more comfortable with other drugs, but many of these dogs present like that one that got the emergency tracheostomy. He presented because he couldn't pee, but then they failed to also note that he couldn't breathe. So there was no IV access, there was nothing. So many times we do need to intervene with some intramuscular sedation right away as we're getting ready to get that IV placed, etc. And sometimes that's good enough. You give them oxygen, you give them sedation, and you start cooling them down, okay? If it's 38.5, you can probably cool them down a little bit. It's okay. They can be on the cool side. We don't want these dogs to feel hot at all. And then if you say, this is just not good enough, or I've given him sedation and I just see the dog struggling a lot, or his stutter is awful, he's very purple, just intubate them. And intubation doesn't mean necessarily now what, okay? Sometimes they just need a moment. They just need to cool down. They just need to wake up feeling fresh, calmer, had a bath. And now we wake up, extubate, and probably ship back home as soon as possible. Or if you say, I cannot extubate this dog, it's when we need to think about a temporary tracheostomy plus or minus corrective BOA surgery. And we are here to help you with that. So just give us a call. Remember, though, that it's not just brachycephalics that can present with upper airway obstructions, right? So we can take off the audio on this one. So if you look at this dog, it's very hard to tell why she's struggling to breathe just by the pattern. It's not super fast, so we say, suspicious. the effort is decent, and then you look at her face, particularly her throat, and okay, now in these 3 seconds, I can already tell you, this is an upper airway obstruction. The dog got bit in her face. She probably has massive throat swelling, and she's breathing like this because she has an upper airway obstruction, okay? Unfortunately, she was so obtunded and so debilitated that she could actually not put enough force on her breathing for you to hear stutter or squeak or whatsoever. But there is no doubt here, this dog has an upper airway obstruction. What about this one? This is the definition of gasping. She has moved to blue, past purple. What do we do? Intubation. Right away, okay? No questions. We are holding some oxygen in front of her. Somebody's placing an IV, and we're going to give her propofol and intubate her right away. No questions asked. Then we can go and tell mom, this just happened. I saved your dog's life. I'm going to try to keep her alive. Let's chat 2 minutes for me to try to understand if it's just tracheal collapse or something else, okay? But it was just tracheal collapse. When we talk about sedating the animals, if we want to give them a chance just to see if they can calm down and see if that's going to be good enough, it does take away the anxiety component of their tachypnea. It does promote that well-being, let's say that, okay, at least I'm not freaking out. I would say that is probably obligatory for all feline patients, even the most debilitated ones. It's very easy to tell if a cat is literally freaking out or not, and it's just not okay to have them having trouble breathing and then freaking out with everything that is happening around them. So every time that there is a cat or anxiety in the dog, or you are just not sure if they have a little bit of too much stress or not, use it. You're probably not going to risk too much. The exceptions would be on the very, very compromised patients. And the example would be that Yorkie that got attacked in her throat, okay? That's the dog that I know that if I give her sedation, which obviously she didn't need because she's already obtunded. But for some people, sometimes, because of they're not sure or they think that still the animal might be a bit too reactive, they will sedate that dog. She will most likely fully obstruct her airway. Why? Because every time that we give sedation, you just relax and you do depress a little bit breathing. Now, I don't like to put too much emphasis on that because that's why I've seen a lot of people scared of giving tranquilizers to animals that were obviously in distress and anxiety at the same time that they're struggling to breathe. So the minority of patients will be so sick that you could in theory risk respiratory arrest if you give that sedation and you're not prepared to intubate, for example, and ventilate. But that's a very petite minority. So back to the questions, just to make sure everybody's paying attention. This is the important. You have a dyspneic patient. Obstructed airway? Yes. Okay. You give oxygen. You cool them if it's a brachycephalic, some sedation. If that's not good enough or you're not sure what's going on, you intubate your patient and take a look. Could be an abscess or a foreign body, a ball, I don't know, a silly Labrador with a tennis ball there, okay? If it's not an upper airway obstruction, we're going to go to the third question. The third question in my brain is it heart failure? Because this is the easiest for me to rule out when it comes down inside of the chest. Is there a murmur? Is there a gallop? Elliot gave away the question I was going to make, which is okay, which is what do we do to find out if it's heart failure? If you are thinking an X-ray is wrong, we do a T-POCUS because this is ECC. T-POCUS. Is everybody familiar with this concept or not? Some others maybe not. It stands for thoracic point of care ultrasound, okay? It's basically that emergency ultrasound, bedside ultrasound that I'm going to do on my dyspneic patient that I've ruled out upper airway obstruction to start taking a quick, focused pick at the organs and the sites that can actually give away right there the answer of why is the animal dyspneic. And the huge advantages is that it's cheap, it's portable, it's painless. You don't need the patient to lie down for a fancy echocardiogram. You don't need the patient to lie down for the x-rays or whatsoever. They can stay right as they prefer, as they're most comfortable with, and it can allow you an immediate diagnosis. Thank you. We can take away any sounds on these ones. So, first video, is this heart failure? And yes, the image is not pretty because this is live videos that we take in the ICU. Just for you. Hand in the air who thinks it's heart failure. Hand in the air who does not know. Okay, I can teach someone. Hand in the air who does not think it's heart failure. There's not heart failure. Why? This is a bit of a crappy, but still diagnostic view of our aorta, and the left atrium is what we call the left atrium to aorta size. Now, gold standard, you take measurements and you say, okay, the diameter of my left atrium is not more than 1.6, 1.7 of the aorta. I can eyeball it, because this is all I do, and say, that looks pretty normal, okay? Another trick that you can do is how many aortas can you squeeze inside of the left atrium? And if it's more than 2, that's probably very abnormal. But this is a totally normal heart of a little dog. What about this one? Who thinks it's heart failure? Who thinks he's not heart failure? Who doesn't know? Oh, everybody already knows. Well, who thinks he's heart failure is right. Aorta. How many aortas can I squeeze inside of this left atrium? So many. Like so many. So many. It is heart failure. I have a dyspneic cat, and then we could talk about the B-lines, etc., maybe in another session. And I have an enlarged left atrium. Until proven otherwise, this is congestive heart failure. We're going to start treating him for that. We don't need to stress him with an X-ray. Next slide, please. What about this one? Tricked you with a different view. Who thinks he's heart failure? Okay. Who thinks is not? It is heart failure. Look how thin are these walls. This is the left atrium, this is the left ventricle, this is the left atrium. We have very thin ventricular walls that don't contract that well. Don't you see? It just looks very incapable of doing its job. And yes, if you would pay attention to the left atrium size, we would say it is enlarged, and we could do the left atrium to aorta ratio, etc. But just this view tells me I have a dyspneic Doberman, probably has some B-lines. The Doberman has DCM and congestive heart failure. Let's start treating him. Diagnosis done. What about here? I'm on the other side, so it's a different view again. Aorta, left atrium. It's literally bigger than my apartment, and it's true. And right atrium. And somebody already mentioned something is going on inside of this left atrium. Okay. This is a tragedy about to occur, basically. It's called ATE. You're all very familiar with it. But this is a dyspneic cat in congestive heart failure. We could probably say, subjectively, he's probably in bilateral congestive heart failure based on the right atrium size. But he's going to throw a clot very soon if you don't do something about it. And unfortunately, even when we do, they can still win that fight. but it's a congestive heart failure patient. Okay, what about if you say, no, it was not congestive heart failure? We go to the fourth question. Is there pleural or pericardial effusion? And how do we clarify that? The same, T-POCUS, exactly, or FAST. We have evolved from FAST to T-POCUS because of brands, and FAST is for trauma. Anyway, it doesn't matter. The ultrasound, yes. Recapping. Airway obstruction, yes. Elliot? Yes? Again? Do something about it. If it's not airway obstruction, is it heart failure? Yes. Great, start treating it. No. Is it pleural or pericardial effusion? Yes. Let's drain it. No. Let's look again. Last question. Is there pulmonary parenchymal disease? You basically have excluded all the options other than that for your patient to be dyspneic so far. So looking at this video, do you see a potential diagnosis of why this dog was dyspneic?
Collapse of the lungs?
Yes. Or what we call hepatization of this lung lobe, okay? So this, you could say, oh, I thought it was a hernia. Fair, because it looks like the liver. But I know it's not a hernia, because I saw the liver in the belly. So this is what we call a hepatized lung lobe. Nothing is inflating there with air. And if I then look at my patient and say he's febrile, he's having trouble breathing, he's feeling unwell, maybe he vomited, this is pneumonia. I don't need an x-ray. I can start treating right now, okay? Next one, please. The downside of having T-POCUS for pulmonary disease is that it does require a trained eye, let's say, okay? And even for me, or for us that see dyspneic patients every day, I do sometimes want an x-ray, you know, because we want to make sure, or a CT scan so we get fancy. But the reality is that if you are able to, with your POCUS, identify big findings, that actually can give you a diagnosis right away. It does not replace radiographs because you can only see a very detailed area of the chest, so you need to be thorough on your assessment. The radiograph will give you a nice picture of both lungs anatomy, okay? Before you say, okay, I've tried my best with POCUS, but the ultrasound machine is actually not even working, so I need an x-ray. Just pause for a second if the patient is very debilitated, review your clinical history, your physical exam, T-POCUS findings ideally, and then ask yourself, is this animal going to tolerate being restrained for that precious x-ray, okay? And if so, remember to always take oxygen with you because no animal should die there. And I think all of us have had them dying there. That includes me. It's not okay. They just should not die in an x-ray table. There is no justification to do that. So we need to plan better and we need to do better to avoid such a tragedy. But it happens to everybody. So, Rhodesian ridgeback, febrile, not eating, feeling unwell, and does have a little bit of respiratory effort that mom actually didn't even notice. We just noticed on the consult. This is his nose. Does he need an x-ray? Who would like an x-ray? It's literally like a 5-year-old kid in December. But the dog is feeling unwell. I don't need an x-ray. And also he's 70 kgs. I can't do that. He has pneumonia. He's got pneumonia. This is a pneumonia case. And I'm just going to find the affected area with my POCUS, and every day I'm going to reevaluate that and see if it's getting better with the antibiotics. Okay? What about these gentlemen? It's, yeah. Delicious. He's having trouble breathing. He's feeling unwell. I mean, who wants to take an x-ray? I don't need an x-ray. He's got pneumonia. Done. He needs antibiotics. Okay? Next one. The nurses were delighted. Now, if you do need an x-ray, just make sure you're prepared, okay? And you just need to get a diagnosis. Does need to be the perfect positioning. Ideally, yes, we want 2 views, but sometimes they don't tolerate that. And if you're worried that something could really happen, just be ready. Have an emergency intubation tray, an ambu bag to ventilate your patient, oxygen source at all times. That includes when you are walking to the x-ray table. And we just try our best without causing harm, ideally. Now, if you do need an x-ray, and because everybody likes to take x-rays, at least may we be able to diagnose them. What's the diagnosis? This is how I torture my interns. If they take an x-ray and I don't think they should, I'm like, okay, so what's your diagnosis? And they're like, I'm like, okay, so what's this?
Collapsed lung loop again.
It could be a collapsed lung. However, look how opaque it is. If you compare this opacity with the heart, with the liver, if we go back to basics, this is soft tissue opacity. And then it's just in such a focal area that, yes, I look at this and I say it's probably arising to the, or from the pulmonary parenchyma, but this is a mass. This is a tumor. And until proven otherwise, this is pulmonary carcinoma, okay? And because now you found it on x-ray, you can even go with your POCUS and take a look at it and say, oh yeah, that's a mass. Now I see it. What about here? This cat was so dyspneic. Somebody x-rayed him.
Looks like cardiogenic edema.
Could be cardiogenic edema, but it's not. Other options. There is pleural effusion, definitely. It's very white. And the heart silhouette is not so easily seen. Now, people that are radiologists will say, you cannot evaluate because the arm is right there, sure. But yes, yes, does have pleural effusion, a little bit. And then look at the distribution again. Yes, pulmonary or edema, particularly in cats, can be so diffuse, but this is just so white. And if you look on the DV, it's not just randomly distributed. It looks focal in this lung lobe up here, in this lung lobe up here. It is a heart x-ray. And I was looking at it and I was like, I'm not sure. I have a guess. I'm going to ultrasound right there. It's masses. This is tumors. Pulmonary carcinoma, okay? In this case, carcinomatosis, because it was already creating fluid. All right? Next one. What about this one? The cat did not want more views. He was like, no. So this was as good as we got. What's his diagnosis? Who is giving him cancer? Some people. Who is giving him heart failure? Nobody. Who is giving him asthma? Some people. Who has x-rayed the cat and now doesn't know? It is asthma, guys. Like, so bad. It's just so bad. That's why it's like, whoa. But obviously, the definition is not the best because this is a picture of an x-ray now on a presentation on the screen for your eye. But if you would be looking at the x-ray, pay attention. These are those donuts, okay? They're just so thickened because he was so full of mucus. Okay, and yes, some people did give him a diagnosis of bad cancer, bye-bye, and I was like, no, wait a second, shot of steroids. And he was fine, he was totally fine. And if you're not sure, you can also just do a little wash, but this was just a very severe asthmatic type of case. He did totally fine with some steroids and bronchodilators. What about this cat? What's his diagnosis? Somebody really wanted 2 views. Who is giving him cancer? Nobody. Who is giving him heart failure? The majority. Who is giving him asthma? The majority is right. This is heart failure. I mean, just the size of his heart, right? He has such severe cardiomegaly. And then remember what we were talking about, the pulmonary edema. It's very diffuse. Yes, the dogs tend to be more perihilar, etc. But the cat will do whatever they want. It's a little fuzzy here. It's a little fuzzy up there. On the DV, you can tell that the majority is on the dorsal caudal fields. This is congestive heart failure, okay? What about here? This is Doberman. He went for foreign body surgery. He was about to come back to recover. And suddenly, he was breathing real bad. And nobody knew what was going on. So we took an x-ray. So what's the diagnosis? It is not. Again. Yes. The heart is elevated from the sternum. And what is in between, other than the ribs, is black. If it's black, it's gas. If it's gas, it's a pneumothorax. When we took these x-rays, somebody was very worried that the animal also had a huge gastric dilation. Okay? And that, as we know, can also impair diaphragmatic contraction, breathing effort, etc. Who's going to tube him? Does he have gastric dilation? It's not gastric dilation, guys. This is all the pneumothorax. So if we look after we've drained him, see that he's gone? That was all in the chest. Nothing was in the belly, okay? So we popped a little chest drain on him, got out those 3 liters that he was keeping for himself, and he still has a little bit of a pneumothorax, but now he's no longer symptomatic, so we can relax and he can go and recover. And if you're wondering what happened, we have no idea, but he's fine. He probably popped a pulmonary bullet that nobody diagnosed before, and he's gone home and everything is good, but he just scared us for a little bit. Okay? Last one. This is a geriatric little dog that arrived, was gasping, got intubated right away. We couldn't see anything on T-POCUS, so we took an x-ray. What's our diagnosis? Perfect. Esophageal foreign body. Yes. Look at the dilation of the esophagus just before that soft tissue mass or this object. Yes, whatever, you know. And how are we going to solve it? We can scope it, but the lady says, I literally have $20. Ta-ta! We can just get rid of it, and then she'll deal with it on her stomach. So we just asked the lady, I mean, did you give her any rawhide or anything like that? She's like, I don't know, I give her everything. Okay, we don't know, we're going to pray for the best, and we're just going to push it to the stomach and wake up the dog and ship her back home because she just has $20. And the dog was totally fine. We called her, we promise. This was not at the Ralph, by the way, but before Sheldon is. but it can happen in your setting. So when we talk, okay, I have diagnosed very well my patient. I have treated him. I've given oxygen, etc. I'm not sure now, when do I stop these? Well, that's when I say, you need to start questioning, does he still need oxygen? Does he still need to be at the hospital? And we're going to adjust that based on, can he now go out for walks without getting tired? Is he breathing more comfortably? Is he otherwise eating and feeling well if I take out the oxygen? And if he does, then regardless of the SpO2 or whatever numbers, he probably doesn't need to be in the hospital anymore. So next one, please. So if you look at this guy, this was a patient in congestive heart failure, and the cardiologists were like, he got to stay on oxygen. They also were talking like this because this is in America, and I was like, what? This poor guy is being tortured by his neighbor screaming, and he he doesn't need oxygen. He literally needs to go home because he's freaking out and freaking us out with his barking. So again, adjust it. Even if he's still tachypnic, etc., he clearly does not care to get his oxygen. So home he goes. And finally, not all patients will accomplish normality. So if you look at this dog breathing, is she dyspneic? Who thinks she's dyspneic? Some people think she's dyspneic. Who doesn't? Who is not sure? Okay. I don't think she's dyspneic because this is my dog at home on my day off. But so I think she's okay. But she has severe bronchomalacia, severe bronchial collapse. There is and a bit of tracheal, of course. There is always this dynamic respiration. But look at her; she doesn't care. Like she's chilling. She had a tooth abscess. I took care of that. Don't worry. But if she's otherwise totally dealing well, sometimes you'll have patients that the best thing you can do is, "Hey, mom, can you come over to look at him with me?" Because then you'll see that the carer looks, not the brachycephalus, the other ones, and the carer's, oh yeah, no, she looks like back to normal. And you're like, oh, this is her normal, okay. Fine, I guess let's go home. But some patients will remain with some respiratory pattern just because the disease is chronic, okay? Whenever all of these that I just taught you, you say, no, this is not working. I'm looking at my patient and I've done everything literally like Marisa told me and I'm still very worried about my patient. Well, then that's when call the Ralph maybe, okay? Even if you just have questions, you can always call us, but sometimes all of these that I've told you is not going to be enough. And that's when we call the big guns, okay? We call out for our high flow machine. It's a machine that can give them way more oxygen. It's much better to support the effort of breathing. And sometimes, even if that's not even good enough, we will have access to ventilation, which is quite complex and definitely needs a proper setting for that to be done. And what that means for some patients is that we can have animals like this. This is a little guy that got referred to us. He was very severely dyspneic. You can see that he's breathing. It was about 100 breaths a minute. This is already in our high flow machine. So to me, this is not good enough. I still have a patient that is going to get fatigued. So we do need to escalate therapy. We're going to go ahead and ventilate him. He was in congestive heart failure. We're going to give him treatment for the heart. We're going to replace his breathing and his lungs with this fancy machine. He rests, recovers, and then we're going to wake him up and we're going to send him home. Even if you did everything totally fine in your practice, sometimes they do need these type of escalations. So we're here to help with those.